Another moment. Give it another moment as people are starting to join the session on this humid Wednesday evening in New York and Philadelphia and Des Moines, Iowa. Also, I'm assuming.
Not too humid, but it's almost 90. Yeah,
that's pretty toasty.
Used to it.
I think we're all starting to get used to it.
Mm-hmm.
Okay, so we'll just give it another few seconds before we get started. Okay, I think we'll kick off now. So hi, everyone. Welcome to the National Blood Clot Alliance Pep Talk this evening. Tonight's topic is mechanical thrombectomy. From DVT to PE, will mechanical thrombectomy change the standard of care for the blood clot patients? We have with us tonight Dr. Carin Gonsalves, and I know I just probably pronounced your name possibly incorrectly, but Dr. Gonsalves is here with us this evening. Also, we want to remind everyone that this is an educational event this evening, and we are not giving medical advice. If you are seeking medical advice, please do speak directly to your own personal physician. Or if you're looking for a physician, you can come to our website and there is a spot available to find a clinician, but this is an educational event for this evening. So a bit about Dr. Gonsalves. She is a professor of radiology and co-director of the Division of Interventional Radiology at Thomas Jefferson University in Philadelphia. Thank you for coming tonight. We're so thrilled to have you.
Yeah.
Over the course of her 2-decade-plus career, she has received several awards and honors, including Castle Connolly's America's Top Doctor in Vascular and Interventional Radiology, Castle Connolly Philadelphia Top Doctor in Vascular and Interventional Radiology, and Castle Connolly Exceptional Woman in Medicine. She has been the principal and co-investor for several NIH-funded clinical trials and has received research awards from the Radiologic Society of North America and the Society of Interventional Radiology. In 2011, she was elected a fellow of the Society of Interventional Radiology for her outstanding credentials, achievements, and contributions to the field of what we call IR. In addition, she is the co-founder as of 2016 and co-director of the Pulmonary Embolism Response Team at Thomas Jefferson University, providing outstanding state-of-the-art care for patients diagnosed with pulmonary embolism in particular. She is also a graduate from the Drexel University College of Medicine, did her internship at Crozer Chester Medical Center, and both her residency and fellowship at Thomas Jefferson University. And of course, last but not least, she is a member of the esteemed Medical and Scientific Advisory Board of the National Blood Clot Alliance. We are so delighted to have you here this evening. This is just new territory for us, so we're super excited to have your participation. But before we get kicking, we're going to turn it over to Todd because we do have some poll questions as usual. So Todd, off to you.
Yeah, we love giving these little poll questions. If you guys could just answer these real quick, we like to compile this data and we're interested. So what is your current knowledge level of mechanical thrombectomy as a treatment for DVT and PE? You got 3 choices: very knowledgeable, somewhat knowledgeable, and not very knowledgeable. Question number 2, the final question: what is your experience with mechanical thrombectomy? I personally had this procedure. Someone I know has had this procedure. My doctor discussed this with me as a treatment option. My doctor did not discuss this treatment option with me, but I am here to learn. I am a healthcare provider or other. So if you could just answer those real quick, and then we'll review the results. And then we'll get into a great discussion on mechanical thrombectomy, which I'm looking forward to because I know very little about it myself. So this is going to be a very much learning experience.
But while we wait for the results, we're definitely getting many more inquiries from the patient community about it.
Yes. And here we go. So what is your current knowledge level of mechanical thrombectomy as a treatment for DVT and PE? 10% said very knowledgeable, somewhat knowledgeable, 32%, and not very knowledgeable, like me, 59%. What is your experience with mechanical thrombectomy? Have you had experience with it? I personally had this procedure. 17% of you are saying that you did have this procedure. Someone I know had this procedure, 14%, and then only 5%. My doctor discussed this with me as a treatment option. And 43% said my doctor did not discuss this treatment option with me. 11% are healthcare providers. So that's interesting. A lot of people want to know about this topic, and I'm really thankful, Dr. Gonsalves, that you're here. And I have a couple of questions for you. I know you've got an excellent slideshow presentation. People just love the visuals, and I already know they're going to learn a ton, and so am I. But before we start discussing mechanical thrombectomy, can you explain what your job is for our patient community? So everyone is aware real quick, you are on the Medical and Scientific Advisory Board of the NBCA. So what is your job? What do you do? Tell everybody what your role is.
Well, first, Leslie, thank you so much for that very kind introduction, and I'm very happy to be here tonight. I am an interventional radiologist, and I will tell you that sometimes my husband still doesn't understand what I do. And he's a surgeon. So an interventional radiologist uses image guidance to perform minimally invasive procedures using X-ray, continuous X-ray guidance. So the great thing about being an interventional radiologist is that, you can get a needle anywhere, a wire anywhere, you can really help somebody. And the recovery is very short because there's no large incisions and to recover from. And, we can really make people feel better quickly without a surgical intervention. And it's really a very exciting field. I will tell you that it's not really a new field. It's been around for decades. I finished my training back in 1999. So, but I was still, not one of the first, maybe first of a few women, but yes, it's a very continually evolving specialty. And I will say that their IR docs are very innovative, and they just have this thirst for knowledge and want to help patients as much as possible using minimally invasive techniques so that they can get back to their normal lives much more quickly.
So this has actually evolved quite rapidly over the last several years, right? And yeah. It's a really good, a lot of patients within the support group that have had the procedure came out, they had very positive results. So I know that a lot of people that aren't familiar with it, that's why they're interested. Can this help me? Will this help me? But thank you so much for being here. Looking forward to your presentation. Leslie, I'll turn it over to you.
Great, thank you. So I think what we're actually going to do now is, we're here to talk about mechanical thrombectomy tonight. There's so much buzz about this now. I feel like more and more patients are contacting us, about this. We're seeing more and more interventional radiologists performing this. So, you talked a little bit about this before, but, what is it? Is it really new? Can you talk about the trials that took place to get us here? And are there currently, trials getting on? And then I know you have a presentation. So I think what we want to do is just hand the reins over to you and start your presentation, and you can kind of answer some of these questions along the way.
Yeah, that'd be great. Okay, so hopefully I can share my screen with ease. You let me know if you could see everything. Hold on, I'm still clicking. View, slide, and play. The poll is still here. Let me see if, I don't know if you guys can take down that poll.
Yeah, I don't see it.
Oh, you don't see it?
No, I don't either.
Oh, okay. All right. I don't know
You
why.
can probably click it off yourself.
Yeah, let me see if I can do that. So anyway, let me see. I just wanted to make sure that I did state that I am a consultant for Inari Medical. And I am also the co-global PI for one of the studies that Leslie just referred to. It's called Peerless, and I'll get into that very briefly. But let's just start with some information regarding PE, which I'm sure many of you already know about. But PE is the third leading cause of cardiovascular mortality in the United States, affecting more than 1 million people per year, and it's responsible for 100,000 to 200,000 fatalities per year. Of course, there's risk factors for pulmonary embolism, such as somebody who may have had recent surgery or trauma, who has been immobilized for one reason or the other, cancer, smokes, obesity, congestive heart failure, chronic obstructive pulmonary disease, oral contraceptives, hormone therapy, pregnancy, but about 30% of patients may not have these predisposing factors, and so we refer these to as unprovoked PE. So just to go in just a little bit, because this will help me discuss some of the clinical trials and why we're using suction thrombectomies and where we're using it in what patient population. There are two classification systems that are currently being used to describe PE. One is from the American Heart Association, and they divide people into massive, submassive, and low risk PE. Now, the massive PE patients, thank goodness, it's about 5% of the PE patient population. So I'm glad that it's a small number, but these patients are very, very sick. I mean, they present, sometimes in cardiogenic shock, with, fainting, respiratory failure. And if we really don't treat these patients aggressively, the mortality rate, as you can see here, can be, up to 65%. Did you have a question? You good?
Oh, it's just, I mean, that's mind-boggling when you think about this percentage.
Yeah, it's very scary. And so this is kind of almost like the massive PE is a no-brainer. You're going to do something. And yes, suction thrombectomy can be one of those some things, but this is something that everybody feels comfortable, whether you're a medical doctor, whether you're an interventional radiologist, cardiologist, people realize that these patients, do have such a high mortality that we just can't wait and do nothing. Now, the submassive PE patients, it's about 40% of those who get PE. And fortunately, these patients are less sick, meaning that they present with normal blood pressure, what we call hemodynamically stable, but they often have what we call right heart dysfunction or strain. And so in the mortality, although the mortality, as you can see here, is much less, about 5% of those patients can decompensate and go into that massive category. And I'll go in a little bit more detail of what I mean by right heart dysfunction or strain in a couple of seconds. The other patient population is the low risk category, and it's about 55%. And the good news here is that these patients typically are going to do well just with anticoagulation or that blood thinner alone. The mortality rate is very, very low. So that's the American Heart Association classification. Then there's, oops, I'm sorry. Hope I can go back. I'm not sure I can go back here. I don't know. It's not letting me go back. I apologize, but I'll tell you, let me just explain to you. So the European Society of Cardiology has a classification system that's a little bit more complex, but it has also three different categories. One is the high risk PE. So that's going to be equivalent to the massive PE patients. Okay. And those patients, again, are very sick. They have right heart strain. They typically have hemodynamics that are unstable and could be, pretty scary, meaning that cardiovascular collapse or arrest. They have leakage of troponin, which is an indication. It's called a cardiac biomarker. And what this is it's an indication that there is ischemia of the heart muscle. So again, these patients are very, very sick. There's no controversy that these patients need to be treated.
And just for lay people, ischemia means what exactly?
Oh, ischemia means like starving of oxygen. So the heart needs oxygen to function properly and not to be injured. That's and pretty much the troponin is indicative that there is an injury going on.
Okay.
Others, I'm sorry, I don't know why I can't go back on my slides, but the other category is intermediate risk PE, and that's actually further divided into intermediate high risk and intermediate low risk. Intermediate high risk, those patients, again, will be hemodynamically stable. So their blood pressure will be normal and they might look okay. They might be, having some difficulty breathing, or they might have a high heart rate, but by and large, their blood pressure is stable. Okay. And then they also do have what we call right heart strain, and also the elevated troponin levels. And then the second classification of the intermediate risk patients is low risk PE. And those patients, again, are stable, but typically have, they can have right heart strain, but they typically don't have both the troponin leak and the right heart strain. So those patients are also at lower risk for adverse events. And then, of course, there's the low risk, which patients do very, very well. So the reason why we make such a big deal and why these classification systems describe right heart dysfunction is that even going back to 1999, it has been shown that the mortality rate for patients who have right heart dysfunction, meaning that the right side of the heart, and there's a right side and a left side of the heart, if you remember from biology and maybe junior high school, the right side of the heart is not able to pump well, and it's really strained, and it's and that if you have that, we demonstrate that in somebody with a pulmonary embolism, typically we know that there is an increased mortality for patients with right heart dysfunction. And in this particular study, they showed that it could be doubled, the mortality rate could be doubled in the ensuing 3 months post-PE if right heart dysfunction is detected. So this is why we are very interested as clinicians, does a patient have heart strain or not? And this is just an example of how we look at heart strain. So there's two ways. You can get a CAT scan, which is on the left-hand side of the screen, which we call it a CT or a CTA. So it's an arteriogram of the pulmonary arteries and the heart structures. Right here, we're just showing the heart, and you could see that the right side of the heart here typically is not supposed to be in normal individuals bigger than the left side of the heart. And you can see here that the ratio between the right side and the left side, the right side is definitely bigger. You really don't need to measure that. And there's also the septum that divides the right heart from the left heart is actually bowed towards the left heart. And that's not normal, because the left heart always has higher pressure than the right. So it really should not look like this. So this is showing that the patient has right heart strain. And then the other way we can look at it is we can do what we call an echocardiogram. And this is just an ultrasound study of the heart. And we get these all the time at Jefferson. We typically everybody gets a CT, but we also do use echocardiography quite a bit, because it feels like, you can really see the function of the heart. And this particular patient has what we call McConnell sign. And this is the right side of the heart here, and here's the left. Again, the right side of the heart looks bigger than the left, right? Mm-hmm. And then what happens with patients with PE, when the pressure in the right heart gets really big and the heart starts getting strained, the free wall of the right side of the heart doesn't contract well, but the apex of the heart is really spared and almost looks like a trampoline. So it's almost hyperdynamic. And this is, what we call McConnell signs. And this is also demonstrating right heart strain.
So for a lot of us that are on this call tonight, we probably, I know I did, experience the doctor coming to do the echo on the heart to see if there was strain.
Oh, yeah. Yeah. And I think it's very common, whether it's the cardiologist, the pulmonary critical care docs, the ED docs, typically, it really gives us added information. So the cardiac troponin levels, I also mentioned, is a sign that the heart is strained and that there is actually what we call ischemia. And it also has been shown that patients who leak troponin, or their troponin levels in their bloodstream are higher, also have a decreased survival compared to patients who don't have an abnormal troponin level. And in this particular study, an elevated troponin level was associated with a 4.5-fold increase in risk of fatal PE. So really, this is, again, why these classification systems have been created, and why we use these particular parameters, and then why we divide patients into these different classes.
So this is dated 2008. Has it changed at all, or is it still the same classification?
So the European Society of Cardiology revised their classification. This is the one that was high risk, intermediate risk with the two classifications of intermediate risk and low risk. They did in the past use another biomarker called BNP, but they took that off. They pretty much are relying on the troponin instead of troponin and BNP. Okay, so let's get to the real interesting stuff. So suction thrombectomy. Okay, so I will tell you, there are a whole host of devices that are currently in either in trial or being developed. This is, as we mentioned in the beginning, it's a very hot topic. Everybody, all these companies want to get their device, on our shelves. And so there's a lot of studies going on, but there are two devices that have achieved FDA clearance for the use in the pulmonary vasculature. And I'm sure many of you have heard of them. One is the Penumbra Indigo aspiration system, which is on the left-hand side of the screen. And then the Inari medical device, it's called the Flowtriever, very pretty purple color. And that's exactly what it looks like. And both of these are just literally hollow tubes that you place within the pulmonary arteries and you aspirate the clot out of the pulmonary arteries. It's very simplistic, but they work. So I'm going to start with a case presentation. So this is a case that's near and dear to my heart. This is a 23-year-old woman. I have a 20-year-old and an 18-year-old. So, kind of close to my kids' age. She was on oral contraceptives. She was status post a recent ankle surgery. She was a lacrosse player and had multiple injuries in college. And she finally, after college, decided to have ankle surgery. She had sudden onset of shortness of breath, chest tightness, and lightheadedness. And pretty much every time she tried to walk from one bench to another, where she lived, she had to stop because she felt like she was going to pass out. So she called her mom, who lived in Virginia, and she was, of course, in Philadelphia. And her mom's like, you need to go to the emergency room. So she arrived in the emergency room at Jefferson with a heart rate of 120. And a 23-year-old who is an athlete, that's pretty high. So right there is a little bit of a red flag. And then more importantly, and I put it in red, her blood pressure was 88/67. So when we talk about this hemodynamic instability, the way we define it is if there's a blood pressure less than 90 systolic, so hers is 88, for at least 15 minutes, or if there's a 40 millimeter of mercury drop from somebody's baseline. So if somebody is hypertensive normally, meaning their systolic blood pressure is 160 and it goes to 100, you're going to be concerned, even though maybe that might be normal for me or even this young woman. So she also had an echocardiogram in the emergency room, which showed right heart strain. And then obviously we got blood tests, which showed an elevated troponin level. We also did, and we often do this, and I think this is probably routine for most places who have a PE response team. We get Doppler ultrasound of the legs if we have time. Obviously, if there's not time, we don't bother with it. But she had an acute DVT of her right lower extremity, and it was her right ankle that was that she had surgery on. And then she went for a CT. Of course, we were all concerned that she had a PE. And based on these hemodynamics and the echo and the troponin levels, she would be classified as a high risk or massive PE. So this is just an example of the ultrasound on the left-hand side. You can see the arrow pointing to, this is the common femoral vein. So this is right at her groin. And you can see that she has a very big filling defect in her vein, and this is her DVT. Pretty scary looking, actually, if you think if that launched the pulmonary, terrifying. And then again, you could see the right heart strain from the CT in the middle, and then you can see the filling defects, the arrows on the CTA on the right-hand side of the screen. So this is just an example of what we do when we take a patient to the angio suite, the IR suite. Like I say, we do everything minimally invasive. So she gets a small incision in the top of her right groin, and under X-ray guidance, real-time X-ray guidance, we can thread a hollow tube all the way up into our pulmonary arteries. So what you're seeing here is just a still of one of our pulmonary arteriograms. And an arteriogram is an X-ray contrast study of the arteries, because you can't see the arteries unless you put the contrast in there. So the black is the left pulmonary artery here and some of the branches. And then this is the right. And here, actually, I don't know if this projects very well, but this should look like this, and it doesn't. There's a filling defect in here. So that means that there's clot in there. And then this too, you could see like maybe this is a normal branching pattern of a pulmonary artery, but here you just don't see it. And so, there's clot, and Leslie, let me know if you could see it, but there's filling defects and contrast just streaming around these filling defects. But there's hardly any blood flow to this woman's left lung. And then this is kind of like, oops, I don't know why I'm having trouble with that. So basically, she's not, half of her lung is not perfusing. So then this is on the right-hand side of the screen, this is the Inari FlowTriever device, which is, again, very simplistic, just a very large hollow tube. I'm not going to say that it's small. It's a pretty big tube. And then it's just a syringe that you hook on the side of it, and you just aspirate. You just basically pull back the plunger, and then the clot gets pulled into the catheter. And you can see here on the left-hand side of the screen, this is just from, this patient's, left side of the lung. And I didn't show you because you could still see the clot on the right. But what was interesting is, and the one thing that I didn't mention, is that a lot of times on the angiography table, we'll take pressures in the pulmonary artery to see exactly how bad the obstruction is. And in her case, she was in, I believe it was the 60s. And afterwards, she went back to normal. So normal pulmonary artery pressure is probably about 20, 25. She was really, it was really up there. So she was struggling. And there's no reason. It was obvious that she had a massive PE.
How long did it take her to get back to normal?
So what's interesting is that on the table, and this is not always, but in somebody who's in such great shape, as this patient was, she was like, "What did you just do?" She says, "I feel like a weight has just been lifted from my chest.
Wow.
I could breathe better." She didn't feel like her heart was racing, and and the oxygen that we had to give her through her nose, we just basically started weaning it down, as she's on the table. Now, I can't say that happens to everybody, but I do think that's not uncommon. I think it's a lot of patients will feel better more quickly.
And just a question. So in her case, she was provoked because she was on oral contraceptives and she had ankle surgery.
Correct. Yes, exactly. So she did have a provoked PE. So it's a disease that doesn't discriminate, right? The young, the middle-aged, the old, so anybody can get a DVT and a PE. Okay, so this is her. She's adorable. And she, again, was a college athlete, and they did a story. She was gracious enough to do a story that we have online on our Jefferson website. But
did you also use this to extract because she said she had a DVT also?
Yeah, so we didn't take the DVT out at that time. She didn't really have any symptoms related to swelling in the leg, and the clot looked a little bit more chronic, but we figured we'd just address one thing at a time, given the fact that she had, massive PE. And then they just treated her with anticoagulation for her lower extremity.
Okay. One of the things that people do ask us is, I may be jumping the gun here a little bit, but we'll go for it. You have this procedure. Do you then have to be on anticoagulation forever if you're unprovoked, or if you're provoked, you're on for a certain amount of time, or is it case by case?
So I would say, most people who are unprovoked, meaning that they have none of those risk factors that we talked about in the beginning, typically our vascular medicine docs will have the patients be on anticoagulation indefinitely.
Okay.
Patients who have a PE or DVT, depends on maybe the severity of the clot, but our docs typically do at least 6 months.
So, and I don't want to jump ahead either, but can any of this be performed when someone has a chronic blood
Yes,
clot?
I'm gonna show you that.
Awesome. Awesome.
So, okay, so the next case is a 58-year-old man who unfortunately suffered a stroke, but actually really was had pretty good function. But he presented with acute shortness of breath and chest pain. Now, his blood pressure was normal, although his echo did show right heart strain, and he did have elevated troponin levels. So he was classified as an intermediate risk or a submassive PE. And you can see big clot here in his pulmonary arteries on the CT. So again, we took him to the angio suite and we put a catheter in this is his right. I know sometimes people on radiology, our left is people's rights. But this is interesting, is that there's good flow maybe to his upper lobe, but there's just this big defect in the lung here that is not getting perfused. And there's a huge clot sitting right in his pulmonary artery. And hopefully I could play this. And you could just see here, it's like, there's just this defect there. There's no flow there. And like I said, we do take pressures in the pulmonary artery when we start, and his was 54. So I said, man, the normal is probably about 20, 25. And that is pretty high for this gentleman. And of course, he's a little older. So he was really struggling too, but he still was classified as a submassive PE. And then, so this is what we look like. This is, again, what the FlowTriever device looks like on the right-hand side. Very simplistic, just a hollow tube, but you can see how much clot we're able to extract from the pulmonary circulation.
Can you give us an idea as to, because we're looking at images, and to me, the device looks so much bigger than it actually is. So can you just give us some context in terms of how big an artery is versus this piece that's going in?
Yeah, I mean, it looks big, but compared to a common femoral vein is, probably, I don't know, at least 2 centimeters or so. And these devices are a fraction of that. So it's not, even though it looks like it's pretty big, the veins, especially like even higher up by the heart and the what we call the inferior vena cava, are much bigger. The inferior vena cava could be like, most normal is it's less than 25 millimeters, so 2.5 centimeters. Okay, so this is the same guy, just to show you, like, this is before, and then now you can see there's perfusion to the lung. Okay, so this patient obviously again felt better on the table, and you could just see the pictures there. Okay, so this is a little bit different, and this is something that we want to talk about, maybe other things that the suction thrombectomy devices have really changed the landscape of how things are being done. This is a 56-year-old man who was stable, presented to the emergency room with shortness of breath and chest pain, and typically our ED docs will start heparin. They'll call a PE response team alert, and we'll all go to the bedside. And we figured this guy had a PE. He did have a CT that diagnosed that, but what was really scary, and this is something else that is, suction thrombectomy devices definitely have changed the way we treat patients. A bedside echo demonstrated what we call clot in transit. And I don't know, Leslie, I'm sure you know about it, but clot in transit is blood clot from the legs. It can be up from the upper extremities, but typically from the legs, that's trapped in the right side of the heart. And this is just an example of that, and hopefully it'll play. So this is the echo. And when we saw this, like literally like, took a breath in and was like, oh my God, because if this clot goes to the patient's pulmonary circulation, I mean, that might be it, that might be the end of the story. So this is something that we take very seriously. Let me just explain, like, clot in transit is really thrombus waiting to embolize to the pulmonary arteries. And probably every clot we know is a clot in transit, but about 4 to 18% of patients who have a PE sometimes you can see this clot that's sitting in the right atrium, and it could be in those patients who have congestive heart failure or atrial fibrillation. And in these patients, they have a condition where the right heart is either dilated, it's abnormal because of their underlying heart disease, and the heart is not pumping well. So the clot is not going centrally into the pulmonary artery. Or there could be clot in the pulmonary artery that's so significant that, remember that I talked about those high pressures in the pulmonary artery, that is preventing the clot from going to the pulmonary arteries. So the very scary thing, though, is that the mortality without treatment is reported as 80 to 100% when you see that. And the mortality is highest within the first 24 hours. So you really need to kind of take this seriously. And of course we do. And the wonderful thing is, in the past, when their patients had clot in transit, typically what the surgeons would have to do is like open up the chest, open up the heart, and remove this clot. So of course the patient had to go on what we call bypass. So they basically, the blood is taken out of their body, put in a filtration device, and then sent back into the body. And it's a big deal. And the recovery, as you can imagine, is pretty significant. You know, it's not easy. So some of these suction thrombectomy devices are, you know, capable of removing clot, sizable clot, without putting patients on these bypass machines. And the two that are currently available that you don't have to go on these bypass machines is, and they're FDA cleared for removal of clot in transit, is the AlphaVac by AngioDynamics, and then the FlowTriever device, as we spoke about. And the good thing is that, you know, especially with the FlowTriever device, you can go up and you can take out the clot in the pulmonary artery circulation. And right now, AlphaVac is being studied for treating pulmonary emboli as well. So that's ongoing study. And there's been several case reports and series that demonstrate safety and efficacy of these devices.
How long does it take for a device to be FDA approved?
Oh God, I don't know if I know that, Liz. I think it could take quite some time. I mean, because the problem is that you got to complete a study. First, you do like one study that shows that the device is safe and that kind of thing, and then you probably will get through the FDA, but nothing's fast through the FDA. So I would say it's probably got to be a couple of years, but I would be guessing at that. But I know that it's not quick.
So just a real quick question out of personal curiosity. So my mom died sudden death in 1984 from massive pulmonary embolism. Didn't get her to the hospital on time. But going back to 1984, can I just ask you, what were the options? I was too young to remember exactly what they did, what they tried. I don't remember anything because my head was spinning. Well, what could they have done had they brought her back and actually got a pulse? Is there anything they could have done for her?
So they could do surgical embolectomy, so they could actually open up the chest and take out the clot, and that's still done today. I mean, these suction thrombectomy devices are I believe, somewhat replacing the need for that kind of surgery for acute PE. So that would be an option. Now, this is before my time. There once was, so all these suction thrombectomy devices are really cool, but let me tell you that back in, I would probably say it was the late 80s, because I did my residency in the early 90s, and this device wasn't no longer being used, but there was something called the Greenfield suction thrombectomy device, and it required a surgical cut down in the groin, but it was a device that you threaded up into the pulmonary circulation, put a syringe on it, and you sucked out the clot. So, it was a device there, but it was a little bit more cumbersome to use. It was very big. It was like, it wasn't like these devices are what we call over the wire. That wasn't. So basically every time you put it in, you got it, you know, when you took it out, you had to start all over and put it back in. So there were devices like that. I will say that, you know, there was also, you know, before these devices, we were doing all kinds of innovative things too, by putting up big hollow tubes into the pulmonary arteries too, and putting a suction. When you all became creative when somebody was dying of a PE, you put everything in the pulmonary artery to get it out. And of course you can do systemic thrombolysis. So you can give through the IV a blood, a clot buster, and that could have saved, you know, your mom's life. But that's a lot of times we use that in the emergency room if somebody is really sick, or, so unstable, we'll give this drug through the IV. The problem is not everybody is a candidate for that blood thinner, or that clot buster, I should say. Like if somebody's had a recent hemorrhagic stroke, I mean, it could cause bleeding elsewhere. So you got to, if it's going to dissolve clot in the body, it can dissolve clot anywhere. So you have a risk of having a hemorrhagic stroke, or you can have a bleed elsewhere, like in the body or something. But if it's life-threatening, I mean, obviously if it's life-threatening, you go ahead and give it.
Thank you.
So this is the clot in transit that we took out.
Oh my gosh.
It's yeah. So that was actually just put the catheter. This is the Inari device. You put it up into the right atrium, and then you just put the syringe and suck. And this all came out literally in one pass. And then you can see the clot is gone. And this is what it looks like. So really changing the way clot in transit can be treated.
And how quickly did this patient normalize?
So very quickly, and we actually went up, and I'll show you the next slide, is we actually took out the clot in the pulmonary arteries as well. So the thing is, sometimes with the clot in transit, if it doesn't go to the lungs, the patient might feel okay until it actually travels there. So but the patient typically, after we removed the clot in the pulmonary circulation, the patient felt much better. So the one thing, it's people are like, well, you're aspirating all this clot. Of course, you're going to be aspirating free flowing blood. So, is these people you just sucking all the blood out of their bodies? Well, the companies are just so innovative, and both the Penumbra system as well as the Inari device, and even the AlphaVac, who's currently being tested, and I'm sure there's lots of others that out there that are looking at this, but there's ability to return the free flowing blood back to the patient, and and filtering out the clot. So in this particular device, this is the Inari. This is called the Flow Saver. This is a 40 micron filtration device and this is my partner, Dr. Eshelman, who's pushing the clot. You can see he had a little hard time getting the clot through here. It goes into this, which is where the filtration system is, and then this is free flowing blood that can be given back to the patient. So the patient, in the past, we were very concerned about how much blood loss. You don't want to exsanguinate the patient, right? So this has been actually also something that's really made these devices very, very useful. And again, the Penumbra also has that as well. And this is just the same patient where we took out the clot in the pulmonary artery as well. So I'm going to ask a little question. So I mentioned that, surgical embolectomy is definitely something that is still performed. But if you had to pick which side of the screen is a surgical procedure where the surgeon went in and extracted the clot from the pulmonary circulation versus the FlowTriever device, do you have a guess? Leslie, I'll put you on the spot.
Going with FlowTrievers on the right.
Oh, you stink.
Right. It does say surgical embolectomy on the bottom of the left-hand side. I don't know if that came up
No,
already.
it just came up now. That was great. I love it. Okay, so we talked, I just wanted to talk a little bit. I don't, a lot of times when you start talking about literature, people will sign off the webinar. But the 3 studies that came out recently, and I should have put the dates up here. They're called the FLAIR, which was the FLAIR study, which was looked at. This is what got Inari FDA approval. Then the FLASH was a really big study, which was a registry that we participated in of 800 patients. And that was the Inari. And then Extract PE was 119 patients, and that was the Penumbra device, the Indigo system. And all these showed they were safe, effective in reducing that right heart strain. The nice thing about these devices is that because patients feel better and more quickly, they have decreased length of stay in the hospital. And then also, unlike the clot buster that I talked about, where you can deliver it through the IV or actually through a catheter that you place in the pulmonary, you don't need an ICU stay. Obviously, if the patient has a massive PE, they're going to go to the ICU, but sometimes we can actually get these patients treated, and they can go to like a monitored floor bed rather than an ICU, which is, cost saving for the hospital. So those have been great. So there are actually some really cool trials going on, and then I'm just talking, I mean, obviously there's so many trials going on for looking at PE, but these are the ones that are either currently ongoing or about, well, actually 3 of them are ongoing, and 1 is coming down the pike. So Peerless is a randomized controlled trial comparing catheter-directed thrombolysis. So that's putting that clot buster directly into the pulmonary artery via a hollow tube, and then comparing it to suction thrombectomy using the Inari flow retriever device for patients with intermediate high-risk PE. The STORM PE is a randomized controlled trial comparing anticoagulation to suction thrombectomy using the Indigo aspiration system. That's also for intermediate high-risk PE. PE Tract is a randomized controlled trial comparing anticoagulation to any type of catheter-directed therapy. So it could be thrombolysis, that clot buster, or the suction thrombectomy. It's basically the operator's choice, and that's for patients with submassive PE. And they enrolled the first patient this week, so that's very exciting for them. And then Peerless 2 is on the horizon, and this is also another randomized controlled trial comparing anticoagulation to suction thrombectomy using the Inari flow retriever device, but it's going to be all comers for intermediate risk PE. So very exciting. I mean, it's really like a fast moving a field, and people are very interested in getting data that will help us better understand the long-term effect of doing all these procedures on patients.
So can people talk to their provider about signing up for any of these trials? Are they open?
So they are. So Peerless is open, STORM PE is open, PE Tract is open. Not every site is obviously participating in it. I think, these patients have to have acute PE. So they're meaning that they have to have a PE that's less than 2 weeks to be qualified for the particular trials. So, but you come to them. I mean, listen, I mean, I am so grateful for any patient who signs up for these trials, because we need data, we need knowledge, and so it's really selfless of them in a time of when they're really, really scared to, allow us to randomize their care. It's really, it's very unique and very amazing. And of course, very selfless, as I said. Okay,
So is it fair to say then that mechanical thrombectomy is still really for high risk to medium high risk patients?
I would say we're using it for all those intermediate high risk patients, and then the high risk. If we typically, what we'll do is sometimes somebody might look really good, but we'll walk the patient. They might not be so much like intermediate high risk, but kind of like, teetering between intermediate low risk, high risk. We'll walk them and see if they decompensate, see if their oxygen, level drops, see if they get really tachycardic. And sometimes in that situation, we'll go ahead and treat them. But I think for now, I would say most people, I'm not saying everybody, but I would say in our institution, we're a little bit more conservative, but we do high risk and intermediate high risk predominantly.
Okay.
Okay, so let's move on to DVT. So this is I'm almost done. Sorry. So 60. Yeah, but you guys interrupted me, so I'm allowed to come.
So we're not going anywhere, so we're here for the duration.
Okay, good. All right. So this is a 64-year-old man with a history of tobacco use. He developed a left-sided iliofemoral DVT. So that means that in the pelvis and then in the thigh. And he was treated with blood thinners and discharged home. He presented 3 months later with significant debilitating left lower extremity pain and swelling, and they did an ultrasound which showed chronic DVT, but also acute DVT. So there was acute, we like to call it acute on chronic DVT. There's nothing cute about it. It's this poor patient had significant leg swelling. So this is just a picture. The left leg is normal, kind of that, thin, normal color skin. And then on the right-hand side, you can see like the patient's leg is swollen, it's red. I mean, this guy had a lot of pain. So, so in this situation in the middle screen is what we call a venogram of the lower extremity. So, and also on the right-hand side too. So what a venogram is just an X-ray contrast study of veins. So this is just an X-ray contrast study of the veins in the patient's leg. And there's a large sausage, a big filling defect in the iliac vein here. And then also in the thigh is pretty much almost occlusive in the thigh. So this guy had a pretty significant clot burden in his leg. And because his leg looked like that, obviously, and was in significant pain, we went ahead and decided to treat him with suction thrombectomy. So there are, you can use for acute DVT, you can use suction thrombectomy device, whether it's the FlowTriever device or the Penumbra Indigo system. The nice thing about the FlowTriever is it is larger and it's great for like iliacs and IVCs, which are a bigger caliber. I mentioned that they can be like 25 millimeters. And so you can put that in, and if it's acute clot, and sometimes even subacute, meaning that it's not fully organized, will come out with the FlowTriever device. But there's another device called the ClotTriever, which I'll full disclosure, I don't do a lot of, clot that is chronic. I leave that to my junior partners, but this is a device also made by Inori, where you put it through the clot. And then there's this collection bag that actually will trap the clot so it doesn't go centrally into the lungs, but it really can remove clot that's not acute. It's more chronic and well organized. This is actually Dr. Winokur, one of my favorites. He's actually up with you, Leslie, up in New York at Cornell. And this is the clot that he removed from this patient's lower extremity. And, this is what it looks like afterwards. Remember, you saw all those filling defects, and now it's nice and smooth. It looks uniform. And so the patient did extremely well. And this is what his leg looked like 2 weeks in the office when he went back to see Dr. Winokur. So I'm just giving Dr. Winokur a big shout out for giving me all these slides.
Amazing.
Okay, so in summary, suction thrombectomy devices are changing the way physicians are able to treat patients, whether it's PE, a massive, submassive PE, clot in transit, deep vein thrombosis. And sometimes you use the device a little off-label, things that are not necessarily approved. But if somebody really needs a procedure that requires removal of, acute thrombus, we have gotten creative and used it in other vessels in the body. And this is actually kind of a neat case. This is my last one that I'll show you. This is a guy who basically had heart failure, and unfortunately he developed a vegetation, which is just material stuck on the tricuspid valve here. It looks like a little ball, and they just were like, we cannot take this guy to surgery. He'll never survive it. And so we used actually the FlowTriever, and we used guidance with a echocardiogram, but it's actually placed in the esophagus, and we had a cardiac anesthesiologist help us guide where to put the FlowTriever, and we were able to suck all this out, and this guy didn't need surgery. And he had before this, he had what we call positive blood cultures. He had an infection in his blood, and after we did this, they were able to clear his blood cultures because they wanted to get him on the heart transplant list. And that's it.
This is amazing. That this exists and it's becoming more and more prevalent. Question for you: we had some people ask about, can it be used for DVT? Obviously, yes, that is being used for DVT. And they were asking about stents. So they've had stents for a while, and obviously there's been a narrowing, and they have kind of chronic DVT situation going on. Have you seen this being used now within stents? This actually came from some of the May Thurner folks that communicate with us.
Yeah, I mean, I think, you can use especially the FlowTriever as the Q clot. You can basically use that to aspirate it, and the ClotTriever, I believe, you can get a little worried about it getting stuck on the stent, but if something's well incorporated already in the wall and it's been there for a while, most likely can be used, but I would defer to Dr. Winokur to answer that question. But a lot of times, yeah, I mean, we can open up stents, whether it's just ballooning it, with a very large balloon, or using some of these devices. But yeah.
So, blood clots can happen anywhere, but is there anywhere in the body that this wouldn't be used or that it can't be used?
Well, sizes could be an issue. So actually the smaller device, the Indigo system, they can use it intracranially, because they have some smaller devices, really tiny ones, or they can use it in the more down towards the legs where the vessels get smaller. So you can use it in upper extremities, that kind of thing. The FlowTriever it's in 16 French, which is pretty large, and goes up to 24 French. It's very, very effective, but you're not going to try to get that into any small vessel.
Yeah.
But I know that they are developing other devices that are going to be more suitable for smaller vessels coming down the pike.
Yeah, somebody has just inquired about jugular, if it could be used for extraction there as well.
Yeah, we've used the FlowTriever in the jugular.
So let me put you in the patient position just real quick. This may be the hardest question of all, but how does a patient advocate for the use of a mechanical thrombectomy? Do they have a say in their treatment? If you were the patient, how would you handle that?
So it's interesting, because I have to say that I grew up on catheter-directed thrombolysis, which is that clot buster. So I will say that both work. And the reason why we're doing Peerless, and there's all these, trials, looking at options on how to treat PEs, because we honestly don't know if there's one that's better than the other. So, if somebody doesn't have any risk factors for, bleeding, especially a young, like even that 23-year-old, if you put catheters in and dripped in a clot buster, she'd likely be okay and have no consequences. And hopefully most of the clot would dissolve over time, but it's a much longer procedure. As far as patients always have an option, especially, when we're part of Peerless, which is a randomized control trial between catheter-directed thrombolysis and the FlowTriever device. I mean, I actually just will tell patients both. And I'm very honest in saying this is why we're doing the study, because we don't know which one is better. We know that patients with the FlowTriever device get better much quickly, whereas maybe the catheter-directed thrombolysis might take, overnight, and have to be in the ICU. So it might be, a little bit longer procedure. But there are many people that believe both of them are equivalent. But I do think that the nice thing about the suction thrombectomy devices is that it does give patients who are at risk for bleeding a real option for treatment of their PE, where we didn't have these devices in the past. So that's what's really, I think, the most exciting. It really does open the doors for a lot of patients who had contraindications to that clot buster.
Can these be used on a saddle embolism as well?
Oh yeah, definitely.
Sure. Yeah.
Yep, absolutely. We use it all the time on saddle PE.
Okay.
What about portal vein or
So-
recanalization?
So portal vein recanalization. So we I don't know if you guys know what a TIPS is, but it's basically in patients who have cirrhosis, is like a stent that goes from the portal vein all the way close to the heart, but it goes through the liver. And we've used it to clean out that stent and then actually go into the portal vein to clean out any clot. But you can also use the smaller Indigo device, again, depending on the patient's bleeding risks. And, it's tough because, like, if they have a lot of fluid in their belly or something like that, you got to be a little careful using these devices. But yeah, I mean, we have used it. I will not say that it is recommended by the company at this point, but it has been used.
Okay, I'm going to jump on another question, and Todd, you take a couple here. But so we have a question: when is it too late to do these procedures? Over 10 years ago, both of my legs have residual clots from hip to knees. Legs look like Fred Flintstone. CT scan showed nothing. Was on birth control but stopped when I got melasma. Over a month of different doctors. Finally, CT scan showed bilateral PE. When is it too late to perform these procedures? I know you talked about the 2 weeks, but for who have had, kind of old clots? Can this be used?
So for in the lungs, like if it's chronic and really organized in the pulmonary arteries, these devices are not going to work, and the clot buster is not going to work. We say 2 weeks, but obviously it's hard to even, sometimes patients can't pinpoint exactly when the symptoms start. So it's a little bit, that's a little bit flexible. But if somebody said, I had a PE 5 years ago, you're not going to get that out with these devices. And that's the time, especially if somebody has what we call CTEPH, which is chronic thromboembolic pulmonary hypertension. That's when patients have to really go to a center that treats patients with this particular complication of PE, where they actually remove all this organized clot from the wall of the artery. So that's a very obviously invasive procedure, but the quality of life for patients who have CTEPH is pretty dismal, with a mortality risk as well. As far as the clot in the lower extremities, again, I'm not an expert, but I've sat next to experts a lot. But I have seen our docs open up chronic occlusions of veins years after it happened.
Mhm.
So that it depends. Like if it's all the way down to the toes and there's no inflow, meaning that there's no inflow of blood that would keep stents open or anything like that, but it is like in the thigh and in the pelvis, and you can open that up, but you have good flow. Chances are those stents, when you open it up, will stay open. Of course, blood thinner is going to be a must, indefinitely. But yeah, so it is possible, but that again is something that you would want somebody who does this a lot.
Mhm. Okay.
Mhm.
Um,
So, I'm sorry, go ahead, Leslie. Were
no,
you
no, no, I
gonna
was gonna
add
say,
on to that?
you go, and then I do want to, there's a question that I do want to give to Karin.
Yeah, so I just have one last one, and this is coming from a couple of patients, but how can patients find out what hospitals have interventional radiologists trained and certified or qualified to perform a mechanical thrombectomy? Should they just talk to their provider? Can they go online and find out where these trained people are, or how do they do that?
Yeah, I mean, a lot of these clinical, if you go on, the clinical trials that I listed,
Mhm.
if you go on to like Inari, I mean, you can get, what sites are participating. You can actually contact the company and ask them like who's involved. But a lot of interventional radiologists these days, believe it or not, in academic institutions, are very well equipped to do these procedures. And I would even take that a step further. There are a lot of even community docs that are doing this. I think it is available in even small rural hospitals, because we train a lot of people and they go out to these small community hospitals and they go ahead and perform, because thank goodness, a lot these catheters are very simple to use. Now, I'm not going to say it's not without risk, and you have to have, great technique, and you have to be well trained. But it is, a good interventional radiologist can do this, and you can probably find out on websites and so I, and as well, and always contact an interventional radiology, division at your nearest institution to see if they do
Right.
it.
Yeah,
Okay,
and I
thank
would
you.
suggest also, if there are people out there that are looking for interventional radiologists, contact us at Stop the Clot and we'll share with you how to find those folks. We're not making recommendations, but we can share with you the process to actually find the interventional radiologist. I have two questions that I'm going to combine as one. So, and they're both great questions. Are there known side effects or complications from mechanical thrombectomy? And what are the risks of this procedure? Can it cause a clot to embolize during the procedure?
Okay, so there are, like I mentioned, it's very important to have good technique, and obviously this is something that we're trained on and we know how to use. So as far as side effects, it is very unusual to have typical side effects that I think of, like when I'm treating my cancer patients, but there could be complications. There could be, if you're not familiar with using the catheter, you could have injury to the heart, injury to the pulmonary arteries, and that could be catastrophic or require, emergent surgery. So yes, but the studies that have been published show that the incidence of something like that is very, very low, in experienced hands. So, but yeah, that is definitely something that is something that we would be concerned about. Now, We usually get an ultrasound prior to any intervention, just to make sure that we aren't at risk of pushing a clot centrally. And, but that's not perfect either, because an ultrasound, a lot of times, the highest you can see is, maybe, a little bit into the pelvis, and all the other veins in the abdomen you're not seeing well. So you could risk sending another clot centrally if there's something that we don't see. But it's also, you remember, we can chase it and typically be able to suck it out.
It's simply amazing to see where this is all going to go. I think we're going to take one more question, because we want to be mindful of your time. We know you're working all day in the hospital and seeing patients, so we appreciate you taking time out of your schedule. My 24-year-old son has had over 15 mechanical thrombectomy procedures to remove DVTs in his leg and groin. He continues to clot and has tried all blood thinners. Concerned that these procedures could eventually cause damage. Is there anything that might be coming to help with ongoing clots? Anything down the road that is in trial that you think might be applicable for someone like this?
Oh, that's kind of hard to say. And that's obviously, I feel really sorry for, got a mother with a son that's going through all that. So it's really hard to say. I don't know of any trials right now. I mean, there's a Defiance trial, which is looking at, a DVT and all that. But I think that sounds like kind of a unique situation. And I'm wondering what else is going on. And obviously, I'm sure he's being seen by a vascular medicine doc to make sure, he's properly treated with anticoagulation. But yeah, I'm sorry, I don't really know anything specific that would help that situation. That sounds like it's
so in this situation, maybe, and obviously we don't know what the situation is either, but it sounds like there's the need for a multidisciplinary team to be working on this particular case. Todd, I'm going to give the last word to you in terms of one more question, and then I think we're going to sign off because we've gone over our allotted hour, and I want to be mindful of everybody's time.
Yeah, well, I'm just gonna, and I can't remember, so I'm sorry, but what is the procedure, and someone's asking this, what is the procedure called to remove the older clots?
Oh, the older clots?
Yeah.
The device is called the Clot Retriever that I know
Okay.
works quite well. But yeah, but thrombectomy would be pretty much what you would call it if you were looking for something like that. If you were searching it on, somebody's, in a hospital website to see who does that. The other thing is the Society of Interventional Radiology is, our society where I think it's FSIR web.org, and they list all the members according to state. So all the interventional radiologists by state. So that might be something that you can look at and see who's in your state, and then you can always, Google them and see, a lot of times they'll list what their specialty is.
Mm-hmm.
Perfect.
Great.
Okay. All right. So we want to thank you first and foremost for joining us this evening. This was amazing. We hope
we've had a lot of great pep talks, but I've never had a whole tablet. I mean, I filled this thing up with notes. I don't think I've ever taken so many notes. So thank you, because that was extremely educational, especially, so many of us just really don't understand what's available, what's out there, how it works. And I think you really nailed it on a lot of different points. So thank you so much.
Thank you. And really, I appreciate the invitation, and you guys are wonderful for what you do every day.
Well, you empower the patients, and that's what we want. We want to educate people as much as possible. So there will not be any exit poll questions, but there will be questions that go to people when they sign off. And just want to remind everybody, there will not be a PEP for the month of August, because PEP is going on vacation during the month of August, but we will be back in September through the rest of the year. And highly, highly encourage everybody who is on here to check out our peer-to-peer patient group that Todd actually manages. He does an amazing job. And if you have more questions about mechanical thrombectomy, he's your man for the time being. And good night, everybody.
Good night.
Good night. Bye-bye.
Bye-bye.